Hello, my name's Jess Dunkley and I'm a trainee nurse practitioner working in a nurse-led abortion care service. I am currently studying at Level 7 to gain competency in early pregnancy ultrasound scanning. In this presentation, I will discuss the role of the advanced nurse practitioner within the abortion service and the implementation of telemedicine for no-test EMA. With the introduction of nurse education programmes, the contemporary role of the nurse has changed compared to previous years. Registered nurses are expanding their scope of practice and are working at a level beyond their initial registration. They are taking on more senior and advanced roles and working at a higher autonomous level that utilises enhanced skills and competencies and often deal with more complex patients and cases. Nurses working at an advanced level use complex reasoning, critical thinking, reflection and analysis to inform their assessments, clinical judgments and decisions. They are able to apply knowledge and skills to a wide range of clinically and professionally challenging and complex situations. There are many different titles that are given to a senior and advanced clinical practitioner as seen on the current screen. There is a recognised need for nursing to be dynamic and respond to change and improve the quality of patient care and optimise the health of the population. According to the Royal College of Nursing 2018, advanced practice is a level of practice rather than a type of practice. Advanced nurse practitioners are educated at master's level in clinical practice and have been assessed as competent in practice using their expert clinical knowledge and skills. Advanced nurse practitioners have the freedom and authority to act, making autonomous decisions in the assessment, diagnosis and treatment of patients. The four pillars that consist of advanced practice are clinical practice, education, research and leadership and management. The Abortion Act came into practice in 1967. This enabled a safe and legal abortion service within England. There are conditions to this act as seen on screen. Prior to this, the maternal death rate due to illegal abortion was significantly higher. Nurses have always been involved in the care of abortion, however, the legal responsibility has fallen to a registered practitioner. There has been a change in abortion methods, especially medical management of abortion, which has expanded new roles within nursing. Although this is still under supervision of a medical practitioner, registered nurses can now plan and manage a significant amount of care for women undergoing an abortion. However, due to the legality of the Abortion Act 1967, nurses cannot authorise abortions. This means that there needs to be two doctors' signatures to proceed with the practice, and this limits nursing activity within the abortion service. Abortion care is widely accessed service within the UK, within 1 in 3 women having an abortion by the age of 45. Many women experience difficulties to this service, such as long waiting times, travel distance or stigma. NICE Guidance 2019 highlighted improving access to abortion care is a key priority. Studies have shown that restricting access to abortion does not decrease the service, but in fact can drive women to seek unsafe abortion procedures that drastically increase mortality rate. As a trainee nurse practitioner within the abortion services, I have the appropriate education and training required to perform some advanced roles as specified in the Royal College of Nursing Termination of Pregnancy Framework. In my new role as a nurse practitioner, my current and future competencies can also be seen on the screen. There are some nurse practitioners that have undertaken on new roles within the service that I work in. These nurses have taken further training to become nurse prescribers, complete family planning courses and are able to perform procedures such as the manual vacuum aspiration, known as the MVA of the uterus, for the purpose of miscarriage or retained products of conception. However, as the current law stands, nurses cannot perform manual evacuation of the uterus for abortion purposes. The advanced training capabilities of the nursing team can see that they are more than qualified to plan, deliver and manage abortion care in their area of practice. However, the limitations of the Abortion Act do not allow them to authorise prescribed medication for abortion. Within the service I work in, the majority of the abortion care is run by the nursing team, with doctors often not meeting or assessing the women that they are signing and prescribing medication for. However, due to the Abortion Act 1967, this cannot change. Telemedicine is the use of information and communication technology to enhance health care and to improve access to services and has been utilised for many years in the NHS. It has been seen to decrease costs and improve the service. Telemedicine has also been used in healthcare for many years throughout, but has not been fully utilised within the abortion care before COVID-19. Raymond et al. 2020 argued that the COVID pandemic threatened access to essential health services, including abortion, across all fields of medicine, prompting a rapid change in practice modules. For patients seeking abortion, urgent adjustments to current protocols were needed to ensure patients can continue to obtain this time-sensitive treatment while limiting transmission of infection by maintaining distance between and among patients and providers. Up to 2018, women who wanted to have an abortion were required to attend a government-approved clinic or hospital for the administration or for the abortion certificate and medication. Despite the evidence suggesting this made access difficult for women, early medical abortion requires the two drugs mifepristone and misoprostol taken 24 to 48 hours apart. These drugs are used to induce an abortion. Improving access to abortion care would deliver significant advantages for both healthcare systems and the women who use them. There is clear evidence that restricting access to abortion does not reduce the abortion rates, it simply makes procedures less safe. Studies carried out by World Health Organization reported that approximately 25 million unsafe abortion procedures were carried out globally. Improving access is likely to benefit those who are most vulnerable, especially in resource-poor settings or where care has to be self-funded. In its 2019 guideline on abortion care, the National Institute for Health and Care Excellence, NICE, stated that improving access to abortion was a key priority. NICE National Guidance 2019 and the World Health Organization both recommended improving access to abortion by making access easier, reducing waiting times, increasing choice for procedures for patients, increasing the expulsion at home for early medical abortion for up to 10 weeks. March 2020, the government changed its legislations to authorise the administration of misoprostol and mifepristone in England. This facilitated the provision of telemedicine. This temporary legislation permitted women's homes as a class of place for both administration of mifepristone and misoprostol. This enabled the fully remote abortion service, improving access and reducing barriers to patients. This remote service is what's known as a no-test DMA. The process allowed consultations which previously needed patients to attend a clinical hospital setting to be seen by a nurse or a doctor to be carried out by video call or telephone. This also allowed the medication to be collected from a clinic or posted to the patient's address. There were many concerns raised by medical professionals of the safety of the no-test DMA. Those concerns included the following: later than reported gestation age, which can lead to increased risk of maternal or hemorrhage or intrauterine death if gestation age is more than 24 weeks, a missed ectopic pregnancy, increased risk or retained products of conception, incorrect administration of the medication, and safeguarding. A study carried out by Bertini in 2021 argued that although telemedicine in abortion care is a well-recognised model and has improved access, patient satisfaction and reduced waiting times, however, it brings the question whether women who would have sought an unsafe procedure to terminate the pregnancy have now found a legal shortcut which still leaves them physically and emotionally isolated from society. CQC further stated that although the results were positive, that there are still concerns over safeguarding of vulnerable patients. In 2018, as the CQC identified telemedicine as unsatisfactory terms in regarding safeguarding. Essential to safeguarding concerns raised in the aftermath of no-test EMA, it is a worry that consultation taken out via video call or phone call can prevent healthcare providers from identifying safeguarding concerns and responding to them appropriately, as healthcare professionals are required to not ask direct questions about safeguarding in the presence of friends, relatives and partners. However, this can be challenging during a remote consultation, as the nurse or doctor is unable to verify if the patient is alone. Research has shown that vulnerable women would benefit from easy access abortion care, such as no-test EMA. However, those with complex needs still require extra time and support, as stated in the NICE Guidelines 2010. Despite criticism from medical professionals and researchers debating that the use of no-test EMA is flawed, studies have shown that many advantages, including accessibility, patient satisfaction and safety. Aiken et al. 2012 published a large study which has shown that the use of telemedicine in early abortion, including no-test EMA, is safe, acceptable and effective. It also improves care for patients. It's further argued that this model is proven to be no inferior to the traditional model used in the medical abortion. Parsons and Romans 2021 further backed up that Aiken et al. Finding, highlighting that safeguarding concerns raised from remote consultation were misguided and carried out on to argue that there is no reason safeguarding cannot be carried out during the provision on a no-test DMA to the same standard as the previous model. They argued that evidence suggests safeguarding efforts may improve where no test EMA is available, as victims of abuse may be able to access services without their abuser knowing. Within the service I work in, changes have been implemented by making the initial appointment a telephone consultation, limiting the amount of appointments patients are attending. However, patients are still required to attend for an ultrasound scan and a consent form, and to take the first initial medication, mifepristone. If no test EMA is fully implemented within the service I work in, there would need to be further training for staff, a thorough assessment process for the staff to be able to adapt to appropriately to ensure patient safety.